Hi guys, welcome back to BROMED Lectures. In this video, we're going to cover posterior pituitary disorders. So for this video, we're going to concentrate more on ADH disorders since it is the most important hormone from the posterior pituitary. So the first one's going to be diabetes insipidus. This one's hard, but we got you covered, don't worry. It's going to be more common in men, and it's going to be more common during childhood. So keep this in mind for the STEMs as a differential diagnosis for these patients. For the etiologies, we divided it into central and nephrogenic. And so for central ones, it is due to a lack of hormone, and for nephrogenic, it's usually due to a lack of response to the available hormone. So for the central ones, neoplastic causes such as adenoma and craniopharyngioma are the leading ones. There's also mentioned infiltrative diseases in which sarcoidosis is commonly tested. Some types of leukemia also infiltrate the gland, cause dysfunction. We have idiopathic causes, usually hereditary causes, and obviously direct blows to the gland such as radiotherapy, surgery, and direct blow with injury. Infectious diseases with encephalitis and tuberculosis, usually tested. And for the nephrogenic part, we have idiopathic. This one is usually due to hereditary lack of response to the receptor of the hormone. And hydroelectrolytic disturbances, hypokalemia, hypercalcemia commonly mentioned, sickle cell disease. Remember, these patients have all kinds of alterations in the kidney due to infarction, due to phosphatemia, etc. Pyelonephritis, infiltrative diseases also of the kidney, such as amyloidosis. And this is where the money is, the drugs. Remember lithium. In a patient with bipolar disorder, this one's commonly tested. The meclocycline and colchicine are also commonly mentioned. And so the signs and symptoms are going to be pretty straightforward. The patient is producing a lot of dilute urine, so he's going to have polyuria, right? And if a patient has the intact thirst mechanism, they're going to develop polydipsia. Now, it is commonly mentioned that these patients develop hypernatremia, but be cautious with this because if the patient is constantly increasing the intake of water, he's going to avoid the development of hypernatremia. For the STEM questions, consider hypernatremia in these patients. These patients are going to have an increased osmolarity. This is telling you that this is a true hypernatremia. And the urine, of course, is going to be dilute with low osmolarity. Now, nocturia is an important hint because this is telling you that the disease goes along throughout the day. So keep this in mind for the differential diagnosis. The patients have a lack of hormone or a non-responsive hormone throughout the day. For the diagnosis, we usually use the water deprivation test. We're going to be focusing more on this matter on the next section of the video. But keep in mind the three differential diagnoses for these patients, primary psychogenic polydipsia being a common one, and the two types of diabetes insipidus. For the treatment, of course, if the patient has a lack of hormone, replace the hormone with desmopressin being the commonly used one, and keep your patient hydrated. For the nephrogenic ones, this is a counterintuitive treatment because if the patient is already producing a lot of urine, why would you give them diuretics, right? So the suggested mechanism for these treatments are you want to avoid to be dependent on the collecting tubules for the ADH. So hydrochlorothiazide and amiloride increase the response of the proximal tubules with you being less dependent on the ADH mechanisms. Indomethacin has a similar mechanism of action as hydrochlorothiazide and amiloride. Keep your patient hydrated and avoid salt to avoid hypernatremia development. So now let's go in depth for the water deprivation test. So in this test, what you're going to do is you're going to restrict the patient from taking water. And so you want to measure urinary osmolarity and the serum sodium throughout the different stages of the test. First one's being the baseline, then the water restriction part, and then the addition of vasopressin. Consider the three mentioned differential diagnoses with primary psychogenic polydipsia, central diabetes insipidus, and the nephrogenic one. For the primary psychogenic polydipsia, what you're going to first notice is that the patient has ADH restriction and the urinary osmolarity is going to be down. The serum sodium is telling you that the patient is hyponatremic due to an overload state of water. And now if you perform in these patients a water restriction test, they are going to behave as a normal patient with the ADH taking place and concentrating the urine and then the serum sodium normalizing. Now for the central and the nephrogenic diabetes insipidus, notice that they may or they may not be hypernatremic. This is due to the different stages the patient may present, either hydrated or dehydrated. If the patient is hydrated, they're going to be normal or slightly hypernatremic. If the patient is dehydrated, they're going to be hypernatremic. For the exam, consider a slight hypernatremia at the beginning, with the patient also having lack of ADH response, dilute urine. Now you're going to perform water restriction, and you're going to notice that these patients are not going to have changes or minimal changes in the concentration of urine, but they're going to further develop hypernatremia. Now this will hint you for you to perform a vasopressin test, in which if the patient has a central diabetes insipidus, the addition of the hormone is going to concentrate urine and is going to normalize the serum sodium, and the patient with nephrogenic diabetes insipidus is not going to develop changes. This is telling you that the ADH isn't taking action in these patients. So in this part of the video, we're going to review SIADH, and we're going to go through SIADH as a pathology standpoint, since what you're going to be presented in real life is going to be a patient that has hyponatremia due to non-specific symptoms such as nausea, irritability, confusion, whatever, and then you're going to work all the way up through the hyponatremia algorithm, and then you're going to get to a specific diagnosis such as SIADH. But in this video, we're going to focus only on the SIADH as a pathology, but the specifics of what you need to know and how is the presentation and the treatment. So for the SIADH, the common etiologies, the most tested one, not the most common, but the most tested one is going to be small cell carcinoma. And the USMLE loves these kinds of pathologies because a different syndrome, a different pathology is going to unfold as SIADH. And so they want you to know the associations. It is not the most common one, but it is commonly tested. And this is referred as an ectopic ADH secretion syndrome, but please notice that there are also other pathologies, other neoplasms, pancreatic adenocarcinoma, etc., that unfold as SIADH, but this is the most common one. So the real most common cause of SIADH are going to be either pulmonary disease and CNS disorders. And this can be various etiologies such as pneumonia, tuberculosis, abscess, head injury, stroke, encephalitis. Whatever is occurring in these two systems can unfold as SIADH. Now for the drugs, I listed some of them, the most common ones, but please notice that chlorpropamide, cyclophosphamide, and carbamazepine are going to be the most common ones, the most tested. Keep those in mind. For the pathogenesis, this is an increased ADH state in which the patient is going to develop increased extracellular fluid volume, but notice this. These patients are usually described as euvolemic. These are the hyponatremic euvolemic patients, and this is due to a response of the heart from the natriuretic peptides generating natriuresis. And so this is going to cause that the patient is not going to develop an overload state, and he's going to be euvolemic. For the signs and symptoms, remember I told you these are non-specific: nausea, vomiting, irritability, confusion, seizures, coma. But the trick here is that you need to distinguish what is acute and what is chronic. And this is going to help for your treatment algorithm. Now for the diagnosis, there are several criteria. I think it was like 6 or 7. But we mentioned the most important ones, the ones that you have to have in mind for the exam, which is a true hyponatremia with less than 130, plasmatic osmolarity telling you that this is a true hyponatremia with less than 270. This one's pretty important, the urinary sodium being more than 20 milliequivalents per liter, described usually as an inappropriate. It shouldn't be doing this, but it does, natriuresis. And it may be caused due to this part of the pathology, but there's also some other things involved behind this, but consider this as one of the possible mechanisms. Now, the urinary osmolarity is going to be higher than the serum osmolarity, which shouldn't be, but is. And so keep this in mind for the diagnosis. And now for the treatment, distinguish either acute or chronic. The acute patients are going to need a more proper, more rapid management. This is because the patient is going to develop fatalities if you do not treat them. Restrict water, avoid developing more hypotonicity in these patients. Hypertonic saline, this is the one that is 3%, and you should correct at a rate of less than 1 millimole per liter per hour. Remember this because this prevents this syndrome, the osmotic demyelination syndrome. And so this is because if you overcorrect or if you rapidly correct the sodium, the neurons are going to give up on their water contents, and this is going to lead to demyelination and a fatality for this patient. So avoid a rate of correction higher than 1 millimole per liter per hour, okay? Now for the chronic setting, this is more simpler, but you should make adjustments in the sodium of their diet, either with tablets or with food. You can add diuretics, especially the ones that increase the aldosterone response in the proximal tubules, because this is going to make you less dependent on the collecting tubules and the response of the ADH. And remember, we mentioned the meclocycline in the last video, the diabetes insipidus one, as a blocking ADH receptor medication. And the newest are the baptins. These are a B2 direct blocker. These are not commonly used, but can be added if the patient is not responsive to other medications. That's going to be for SIADH.